For those of you that don't know me, Steve Shortell, and I'm professor of health policy and management here at Berkeley and dean of our School of Public Health. Give you a little bit of background because this is going to be the final presentation in a year-long series we've had on implementing healthcare reform in California. And some of you may recall that back in October, we started with Peter Lee, who heads up the California Health Exchange, now called Covered California. They experimented with other names like avocado, true story. That did not win. A couple of others did not win. So Covered California did win. So Peter got us started talking about the exchanges and the coverage issues and all of the challenges that Covered California is going to face. And that was a great start. And then we had Bruce Bodakin, the outgoing president of Blue Shield, and Larry Levitt from the Kaiser Family Foundation talking about what health reform and the added coverage is going to mean in the private sector and also for Medi-Cal. So that was our second presentation. We were going to have then try to get the perspective of pharma and Genentech and so forth with Kurt Leidinger from Genentech, but 2 days before his presentation, he threw out his back rather severely, and some of you may have wondered why we canceled that, and that's the reason. And being late in the semester now, we're unable to reschedule Kirk on that. And then a few weeks ago, in March, we had Secretary Dooley here in this room, as you know, talking about Get Healthy California, the governor's report that came out in December. And so today we're winding the series up, and it's actually going to dovetail very well with Secretary Dooley, her presentation, and also how we started out on coverage, because as challenging as expanding health insurance coverage for more people in this country and here in our own big state is going to be, the even bigger challenge, or perhaps at least as big, is whether or not we as a country or as a state are going to be able to sustain that coverage over time. Because that's going to depend very importantly on changes in payment and how we deliver care. It's about delivery system reform. And so over the past year and a half, we've been privileged to bring together the leaders in the state who are working on that side of healthcare reform. And I'll list them here in a minute, but they're the presidents and CEOs of the big health insurance plans and our integrated delivery systems, along with some of the public policy people, to engage that particular issue and what's the vision for California to begin to address the affordability kinds of issues that the expanded coverage really raises. And we're also fortunate today, I'll give them an extended introduction later on, to have two of the people from the systems we've been working with, Tony Barrueta from Kaiser Permanente here in Oakland, and Wade Rose from Dignity, who along with their presidents and CEOs have been very involved in working with us on this, Dignity being San Francisco based, but also in other states as well. So Brent Fulton and I will lead off with some of the key findings and recommendations from the report. It came out February, near the end of February. We will be releasing the appendices and in the weeds technical details on this for those of you who may be interested in that sometime in the next week or two as well. We'll make those available online. So we will go through this in about a half hour or so, I think, dividing it up. And then we're going to turn to our two discussants here for their reactions to some of this and what their own systems are doing to step up to this challenge, and then open it up for all of you. So that's where we're headed. We'll get started with that then. This is our team, and I really acknowledge this has been a wonderful experience for me to work with all of these people. Basically, the analytics staff has been provided by our Petris Center that Richard Scheffler heads up, and he has served as the forum vice chair with me. Ian Morrison has been the facilitator. He's a nationally, actually internationally renowned policy wonk, if you will, but also a wonderful facilitator. And then the other key people, Leora Bowers, Director of Health Policy and Practice for the Petris Center, really played a key role in all of this, along with Brent Fulton and Claire Connors. And I know, is Claire here today? I want to recognize if they are able to be here. Leora is in Israel for 2 years, and Richard is in Spain on his sabbatical, so they are not here today. Sue Kim, one of our former doctoral students. Tien Pham, one of our undergraduate majors in public health, has been the glue of this in so many respects with logistics and scheduling meetings. And then again, some of our students here at Berkeley, Chris Whaley, PhD candidate, and Evan Gallagher over at the Goldman School. I should pause here and say that this whole series is also co-sponsored, not just by our school, but by the Goldman School of Public Policy, and also by our Robert Wood Johnson postdoc program in health policy. So this has been the team. It's been a wonderful team to have. So the outline here, we're going to be following this outline pretty much. These are the participants, to give you a feel. Anthem Blue Cross, Pam Kahali, one of the large health insurers in the state. Blue Shield of California, Paul Markovich is now president, but Bruce Bodakin was during most of the study. Paul's listed there. Also Dave Jones, the insurance commissioner in the state. Secretary Dooley, I've mentioned. Tom Prisolak is the president and CEO of Cedars-Sinai. We had great balance south and north, which is important in this state. Lloyd Dean and Wade Rose at Dignity. Then, of course, we have HealthNet, Jay Gellert, and we have Healthcare Partners, this is the big medical group in the state, Dr. Robert Margolis. Kaiser Permanente, Mr. Halverson, Tony Barrueta. Memorial Health System, Southern California around Long Beach, Barry Arbuckle. And then Monarch, big medical group in Orange County, Sharp in San Diego, Sutter up here, Sacramento-based, as you know, as well. And then the regional office of HHS, also a part of this, Herb Schultz. The asterisks are very important to note, particularly in a public forum like this. These are people from the state. Because of the nature of their positions, we have the footnote here that they're in no position to endorse. It does not represent any of the viewpoints of their offices or their official individual capacities as elected appointees in those offices. But most of them were very fully engaged, Secretary Dooley in particular and Herb Schultz in particular in our discussions, and contributed a lot. Group photo, we're not going to identify people by name. Some of them like their photo, some do not. So we'll just leave it at that. But it was quite a group. That's Richard Scheffler, and that's Leora Bowers there. And that's Brent Fulton. And those are the only culprits I'm going to identify. OK, so this is the report. And it looks like hard copies there. Also, it's on our website, and you're welcome to look at it. And we'll get into the content. Key slide. This sets up everything else we're going to talk about pretty much today. It looks busy and hard to interpret, but I think it'll be easy once we orient to it. Right now in California, 80% of spending, roughly, is still fee-for-service. The more you do, the more you get paid. It doesn't matter necessarily whether it's effective, retests, hospital readmissions, et cetera, et cetera, et cetera. By and large, some changes recently, of course. Okay, and over 2/3 of people, even in California, receive care from low or moderately integrated care systems. I'll explain this in a minute. If you look at this bar over here, this here is about payment. These are dollars, billions of dollars here. And in the orange just shows how the majority of Californians, 2012, receive care under this fee-for-service reimbursement system. Some of them receive care under really what we call partial risk, and the other under actually what we call full or dual risk, capitated, if you will. And the difference between those two is the partial risk is they may be capitated for hospital inpatient care, so much per member per month, a budget, if you will, or for ambulatory care, right? So that's the partial, but not both. Under the full, it's both. Okay, think Kaiser, for example. And then the rest is fee-for-service. So those are actually the dollars. This simply converts it into the number of people in the state that are getting their care that way. So as you can see here, 20 million, et cetera, et cetera. This, in the blue shade over here, is about are they getting their care from systems that use more evidence-based management, have disease transition management programs, use diabetic nurse educators to follow up, are heavily invested in electronic health records, do a lot of self-management, et cetera, et cetera. And what we did here is we got a proxy measure for this, looking at the demographics, if you will, the practice ecology of all the medical groups and practitioners in the state of California by size. And we have a fair number, about 50% of physicians in California are in medical groups of 100 doctors or more. On the other hand, we have 49% that are still in medical groups of less than 5 doctors, okay? And the reason size is a proxy for integrated care is some research we've done over a period of 10 years now here at Berkeley, looking at the extent to which medical practices in the United States actually practice evidence-based medicine for patients with chronic illness. We looked at diabetes and congestive heart failure, depression, and asthma. And it correlates quite strongly with the practice size. As you might imagine, larger practices have more resources, can invest in electronic health records, and so forth. So we mapped that onto California's practice population. And by doing that, we're able to get at least a guess or a reasonable estimate of fully integrated or completely integrated. That's basically Kaiser Permanente. Practices 100 doctors or more, practices here who are at least in IPAs, independent practice associations, where they have some of the infrastructure for integrated care. And then, of course, a lot that are patients receiving care from doctors in small practices that don't have some of those capabilities. So given this, the vision, the central vision that this group of leaders in the state have said is if we're going to have a more cost-effective system and save the state some money over the next 10 years, we've got to get rid of this toxic fee-for-service payment that we're still under, and we've got to get more people, particularly the chronically ill, into care systems that are actually systems of care, okay? And so basically, that's the forum vision. And everything Brent and I will talk about will drill down on that, with a particular focus on the 553. Some of you may be familiar with the 550. Nationally, 5% of Americans account for 50% of healthcare expenditures in this country. In California, that ratio is 553, right? These are the dual eligible, people with a lot of chronic illness, the homeless, they have a lot of mental health problems, they're disproportionately obese, et cetera, et cetera. They're fragile, they are the fragile elderly as well. And it's this population in particular that we need to do a better job of caring for as we move forward. So the vision you can see here is to basically double or integrated care from 29% to 60%, reduce the fee-for-service from 78% down to 50% within the next 10 years, and a big emphasis on population health. And Brent will talk more about this in terms of physical activity in particular. All of this is part of what Dr. Berwick, when he was at CMS, popularized in terms of the triple aim for all Americans, right? Better care and better quality, better health at a lower cost. This just is a visual that shows going from the 29% to the 50% in terms of the payment reform, and then the visual in terms of getting more people into integrated care systems. Now, this is a very savvy group of leaders and not naive enough to think that there aren't going to be challenges to doing all of this. And just to give you a feel for that, one of them has to do with the concern that as providers aggregate up into these integrated care systems, or even the existing ones get larger, the concern is that they'll be able to raise prices when they negotiate, right? And so the whole antitrust issues and regulatory reform that needs to occur around this. And so we gave this a lot of thought and attention. We can get to that with your questions later on. Another issue in this state is we have a lot of self-insured employers. They're looking to save money with their employees. So they have a lot of defined contribution plans, means they pay up to a certain amount, and after that you're on your own. Or some of the people choose these high deductible plans as well. And so that pushes them into care systems that may not be as integrated as one might like to see. pushes away from the HMO model towards these PPO kinds of models, preferred provider networks and so forth. So that may be another issue if the vision calls for getting more people into integrated care systems, right? And then there's, other issues as well, and we can go into those. So we recognize the challenges. So let me put some numbers on this and show you what will happen if we don't do anything or if we take some of the actions that the forum represents or suggests. So that's the trend line of the gross state product. In California, we now spend slightly over 15% on the gross state product, as you see there, and that's going to go to 17% by 2022 over the next 10 years if you use 2012 as the benchmark. And we are projecting into that a variety of different data sets. We're taking into account the implementation of the Affordable Care Act, the expanded coverage, et cetera, et cetera. Okay, now let's look at it differently in terms of household premiums. And this surprised me. I was not personally aware of this to the extent that you see here is the percentage. This is for individuals, I believe, or no, this is the individual line here, single person. This is the family line here, health insurance premiums for single and family coverage as a percent of the median household income in California. So at the current rate, in 10 years, for a family of 4, they'll be spending a third of their income just on health insurance alone, okay? And for a single individual, you can see here. So that's pretty alarming as well. As a result, through a lot of discussion, we had about 4 or 5 meetings, a lot of phone calls in between, our group identified a number of interventions that could begin to change that situation while making the quality of care and the health of Californians even better than it is now. And the big one really is around global budgets, moving away from fee-for-service, and more people in integrated care systems. And if that were able to occur, you can see the projected savings here, and Brent will go into this in more detail, but over the next 10 years, it would be $110 billion a year. And as you can see here, that actually amounts to, it'll be on another slide, about $800 per family every year in savings. And this just shows it in terms of columns and numbers, 83 billion. These are the potential savings from some of the interventions, the other interventions that have been identified and that we will talk about. And that's the 110 billion, reduction of 2.5% of the $4.4 trillion that we will have spent over that, or by 2022. So this just shows it in terms of the line. What that means, I showed you earlier, the 17.1% of the gross state product, with certain things already in force now that might be held to around 16.9, but with the Berkeley Forum vision, and Brent will explain why this is flat and it still goes up, but it's below this, we can bring that down to 16.5% of our gross state product. And think of what we might be able to do if we were able to save 110 billion in terms of redirecting that to other determinants of health in our healthcare system. Because we all know that healthcare delivery itself contributes maybe 10% or so to health. And about 40% is environmental conditions, maybe another 25-30% personal behaviors, and 25-30% are genetics, which is also modifiable as we learn more about epigenetic phenomenon. So if one could begin to implement some of these things we talk about here, we could potentially redirect some of the state resources into things like education, housing, transportation, safety, public safety, that probably has more to do with the health of the population than what our delivery system is able to do by treating people after the fact. Still very important, no question about that, but not really where a big payoff is to improving our health status indicators. So I think with that, this here again just shows what that would amount to in a different way. This is the baseline. Here's what it would be in 2022, baseline 2022, getting down to this figure here. And again, it would be 0.8% of growth above the gross state product. things are evolving 1%. If nothing happened, it'd be 1.1 above the gross state product. So the basic idea is to try to keep the rate of increase in healthcare expenditures in the state no more than the rate of increase in the gross state product. Massachusetts has set as a goal, just as an example, basically to keep it at that and even lower it by 1% or 2% over time. So with that, I'm going to hand it over to Brent now, who will talk about some of these specific interventions and begin to drill down, and then I'll come back and talk a little bit about the relationship to Get Healthy California and Forum 2. What's the ongoing action steps that will be taken to try to see if this can happen? Brent.
Well, thank you, Steve. So as Steve mentioned, the Berkeley Forum selected these 7 interventions to try to estimate how it would improve the triple aim. And before I talk about each intervention, I want to step back and talk about how did these interventions get selected, because the healthcare sector, one of the most distinguishing features of it is 9 out of every $10 that's spent in healthcare does not come out of the patient's pocket. It comes out of Medicare's pocket, Medicaid's pocket, or a private insurer's pocket. And that's much different than any other sector where there's a backstop of the consumer being very price sensitive. And so that's why part of the vision is setting up a global budget. I can give you an example. A friend of mine from college used to wait tables in the summer. And he said whenever you got a big group of 10 or so people, the manager would always say, tell them you can't give individual bills. Just tell them it's administratively too complex. Get a single bill. But the reason they wanted to have a single bill is that way you have 10 people at the table. They're going to end up splitting the bill. And so all of a sudden, everybody's ordering appetizers, drinks, and whatnot because they're getting 90% discount if there's 10 people at the table. So what we want to try to do in healthcare as part of the Berkeley Forum vision is that, okay, we're all at the same table, but now we split the bill, but we have a global budget. That's what you want to tell the waiter. And so having some sort of backstop in the global budget in this case is an example of this is what Blue Shield did in the Sacramento area. So they formed an accountable care organization, Blue Shield of California, with Dignity Health, which was the hospital, and Hill Physicians, which was the medical group. And with the CalPERS population, they formed an overall accountable care organization that had a target global budget to serve this CalPERS population. And if savings were generated, meaning they came in under the budget, those savings would be shared between Blue Shield, Dignity, and Hill Physicians. If they went over the budget, then those organizations then would incur losses. So having a global budget or some sort of backstop is important, particularly in the healthcare sector, because most of payments are paid by a third party. So these are organized in order of the expenditure savings that they generate over the 10-year period. But I also want to show a different organization. There's 3 that have to do with delivery, patient-centered medical homes, palliative care, and the use of nurse practitioners and physician assistants. And then the other 3 could be considered preventive measures. As we all know, in California and the rest of the nation, there's an obesity epidemic that leads to chronic conditions. And so this is physical activity is a prevention effort. And then also preventing health care, particularly hospital-acquired infections, and also preventing the number of preterm births. And so these 7 were selected using a number of different criteria. The most important criteria was what the forum participants wanted and thought that would be most high value added collectively among them, but also within their individual organizations. UC Berkeley served as a neutral facilitator and also a research arm, but the Berkeley Forum participants that Steve mentioned at the beginning were the ones who selected these 7. And so as part of their interest, they had a few criteria. One of the most important one is they thought that collectively they could make more of a difference in these areas than acting individually. They also wanted to make sure that there was a business case, that they had to go home to their organizations and make sure that it was at least financially viable for them to implement these different initiatives. And the other most important is the triple aim, that they're looking at the value proposition. These next set of slides are focusing on expenditure reductions, but the fuller report talks about how it improves quality and also how it improves overall population health. And then the Berkeley, the UC Berkeley folks wanted to make sure from an empirical standpoint that, that we'd have evidence to support the estimates of the expenditure reductions or the quality improvements, and also the overall feasibility of implementing the initiative. One initiative that was discussed that ended up not being on the list of 7 was administrative simplification. There's armies of people at, in hospital systems and medical groups in their accounts receivable department trying to get payments from the health plans. The health plans have armies and the accounts payable paying those bills, and there's a lot of administrative waste. If you look at the United States, administrative costs for health care versus in Western Europe and other OECD countries were much higher. And so administrative simplification, there is a potential to have great healthcare savings, but the issue is it's very tough to implement, that they felt that they would have to almost start over from scratch to have a common billing system, and it would just not be feasible to implement, at least in the short run. So this slide is not meant to read, but what it shows you is a key table in the report. These are the 7 initiatives here. This is a description of the initiatives. And for each initiative, we had a key indicator. So the global budget's integrated care systems, the key indicator was the % of insured Californians that were served in a highly or fully integrated environment operating under a global budget. And we estimated that to be about 1/4 of the population now. Under current developments, the goal would have that reach 45%, and under the Forum vision, the goal would have that reach 70%. I'll go through some of these others in the next couple of slides, but this gives you an idea of the particular measure that we looked at, and then where we are baseline in 2013 and what the goal would be in 2022. So these next 7 slides go through each initiative, and they're organized in a similar fashion. There's a background, for example, in this one, that although we have 44% of Californians who are part of an HMO, as Steve said in the earlier slides, many still receive care in a fragmented system, and 4/5 of the dollars are still spent or reimbursed via fee-for-service. We talk about the Forum Vision goal, then the estimated expenditure reduction for this particular initiative over a 10-year period. And then we talk about the barriers to implement each initiative. So I'm going to highlight a couple aspects of different parts of these slides. So on this one, I think a key aspect is the estimated expenditure reduction. This generated the largest reduction out of the 7 initiatives, almost 80% of the $110 billion. From this initiative alone. And the way we estimated these savings is we looked to the literature and also interviewed key experts who have implemented similar accountable care organizations or global budgets. So I talked about the Blue Shield accountable care organization in Sacramento. During their first 2 years, they averaged 7% expenditure reductions. In Massachusetts, as part of the Blue Cross Blue Shield of Massachusetts alternative quality contract, they generated about 3% in savings. And then, as you know, Medicare has the physician group demonstration project. They generated savings of about 1 to 2%. And so what we did is we took these savings by population, whether they're Medicare, Medicaid, private insurance, applied those savings to per capita expenditures, and then estimated what the savings would be over the 10-year period. And so we applied a similar method to each of these 7 initiatives. So this generated, over the 10-year period, almost 2% of overall spending. So the overall spending projected under the status quo is $4.4 trillion in California over 10 years. These are current year dollars. And the savings here would be about $83 billion, which represents 2%. And you'll notice, we always report the 2022 figure, because what we did is we had the penetration increase. It wouldn't go all the way up to the full forum vision immediately, so the penetration increases. So by the year 2022, this reports what the percent of savings would be for that particular year, and on a percentage basis, it was always typically higher. So patient-centered medical homes are what I want to highlight here, and this was an issue also with preventing preterm birth. So a patient-centered medical home is you're going to provide case management, dietitian support, patient reminders, and so forth. You're going to invest in these patients who have a chronic condition to try to keep them out of the emergency room, to try to keep them out of the hospital. But one of the biggest issues is, what patients do you target? Because if you target a wide swath of patients, it's going to be very expensive. And so the idea, I'll give you an example of dealing with a small child. So you want a small child to clean the room. So you offer them a cookie. And so your hypothesis is, if you don't offer them the cookie, the room doesn't get clean. If you do offer them the cookie, the room gets clean. So that's what you would like to have the outcome be. But there's two other categories that could happen. One is that you didn't have to offer them the cookie anyhow, they would have cleaned their room. I think that's a very small percentage. The percentage I deal with is you give them the cookie, they eat it, but the room still doesn't get cleaned. So when you're looking at interventions with people with chronic conditions, or you're with pregnant women, trying to decide who to target is, if the person was not going to end up in the hospital, the emergency room anyhow, even though you gave them these services, if without the services they still didn't end up in the hospital room, then in a way that money was ill spent. If they're going to end up in the hospital no matter what you do, and you're not going to really reduce the cost by providing these extra services, then that money's ill spent. What you want to try to do is target the population that you're actually going to have an effect. And that's very difficult. So you'll see the savings in some of these patient-centered medical homes and also preterm births are lower than you would expect. And one of the key drivers is we estimated what the cost would be to provide these services, not only the ones who would benefit from this, but also the ones where we wouldn't have a substantial benefit. And so this one targeted people with at least one chronic condition. So that's the key highlight I wanted to do for patient-centered medical home. The use of community-based palliative care, this is a very interesting one. It's also, there is a targeting issue. And when we think of palliative care, it's essentially symptom management, it's pain relief. It's normally associated with end-of-life care, but it doesn't have to be. It can be somebody who's going through cancer treatment and they're expected to survive. They still need palliative care. And what's important here, if you provide the symptom management, the pain relief, it not only can help the patient, but it also can help the caregivers. There's many studies out there that show that the caregiver and the stress associated with taking care of somebody who is in chronic pain, is not being managed well, they can develop their own health care problems, and then it costs the system money. So if you look at Medicare's budget, roughly 1/4 of the budget is spent on 5% of the people who in Medicare die each year. It's a very substantial portion. And so there's a number of studies that demonstrate if you get people into palliative care, they're going to not go to the emergency room as much, less inpatient hospitalizations, and also their quality of care and their quality of life is going to be better. And a recent study came out that even showed that they live longer as compared to people who are being provided the curative treatment. But one of the biggest issues that the forum recognizes under the fee-for-service system is that the reimbursement for palliative care is just not large enough to provide not only the physician or a nurse practitioner, but also the social worker, religious clergy, to help with the overall situation. And it's not large enough. So under a global budget system, the money is more flexible and they can put the money where they think they're going to have the largest payoff. So increasing rates of physical activity in the state, there's roughly 50% of Californians who are considered inactive. These are people who walk less than 30 minutes for 5 days a week. And so prevention came up and up again at the forum, that they realized, yes, we are the healthcare delivery system, but as the dean said, the healthcare delivery system affects maybe 10% of population health. There's a lot of preventive issues, environmental, behavioral issues that need to be focused on in order to reduce overall healthcare costs. And so what the goal here was, it was a modest goal to reduce inactivity by about 5 percentage points. And the reason it's fairly modest, it's somewhat hard to change people's behaviors. And the walking thing, what are we going to do? Offer them a cookie and then have them walk? That would probably be negate what we're trying to do. So it's changing people's behaviors is very difficult, and a lot of large employers have experimented with different payment structures to try to influence behaviors, to stop smoking, to walk, to join a gym, and so forth. But it's very difficult to do. But we thought that with the collective participation of the forum, with their reach across the state, that 5 percentage points was an attainable goal. And this would reduce spending in the short run, this is a 10-year horizon, by $8 billion. It's a small percentage. We think most of these savings would occur outside the 10-year window. So increasing the use of physician assistants and nurse practitioners. So in California as a state, we use fewer than the US average of nurse practitioners and physician assistants, about 45 per 100,000 in California versus 60 in the rest of the United States. And physician assistants are about the same percentage, about 75%. If you look at their overall wages, though, physician assistants and nurse practitioners in California, their wages are about $90,000, about 1/2 the wage of a primary care physician of $180,000. And so the issue, again, here is targeting. If we want to increase the use of nurse practitioners and physician assistants to save money, it's important that the care that they provide is what they're qualified to provide. So there's a number of studies that show under certain conditions that their quality of care and their health outcomes are very much the same as a primary care physician. But the concern is that the overall spending, that there have been a couple studies that the resource use, the number of lab tests that they order, the other diagnostic tests, can be a little bit higher than a primary care physician. So the targeting is that in a team-based environment where a patient comes in as a complex case, it's the first-time visit, that might be go to the primary care physician. But once the diagnosis is established, it's a follow-up visit, then could that be done by a nurse practitioner or a physician assistant at a lower cost and still have relatively the same quality and the same outcomes? One of the biggest barriers here, though, is the scope of practice and licensing, that there's very clear scopes of practice of who can diagnose. In the state of California, for example, nurse practitioners, they cannot practice independently in the state. They have to be under the supervision of a physician, versus in about 1/3 of the states in the United States, they can practice independently. And so that's one of the barriers that could impede increasing the use of nurse practitioners, because if they can't practice independently, the byproduct of the act also is that then they're not empaneled in let's say, a health maintenance organization. They're not able to have a panel of 2,000 patients that a primary care physician could have. So this is initiative 6, reducing the number of healthcare-associated infections. I'm sure we've all heard stories of people going to the hospital, go in for a relatively minor surgery, and then it's exacerbated by an infection that's acquired. The Institutes of Medicine documented this 10 years ago in the Quality Chasm report, saying that approximately between 50 or 100,000 people are dying unnecessarily in our healthcare system. So this is a key issue, and the vision here was a 5% reduction in 5 key healthcare-acquired infection areas. The overall spending reduction was roughly low, but we weren't as concerned with that because the main thing here is quality of life. The estimates, if you look at the impact on quality of life in the United States overall for hospital and healthcare-acquired infections, the dollar amounts are between 30 and 45 billion. So they're very considerable. These expenditures that we estimated the savings were just directly to the healthcare system, not actually estimating what the patient would value them at, which would be much larger. And the final initiative is reducing the number of preterm births. Overall, California starts at a better place than the rest of the U.S. The rest of the U.S. is at about 12% preterm birth rate. We're at about 10%. And so to get it down much lower, it becomes more and more difficult. If you will, they've gotten the low-hanging fruit. And so, but they still felt that there were some room for improvement. Again, the savings here are fairly low. If you prevent a preterm birth, particularly one at 26, 30 weeks, they're very expensive. There are a lot of savings that are generated. But it's this target efficiency that we felt we had to target a number of people who had at-risk pregnancies. We realized some will still have the preterm births, some won't have them no matter what we do. And so the ones that we would actually reach and have an effect on were a smaller percentage than the overall that we would target. But the health outcomes, not only for the mother, but the child during that first few years are pretty pronounced if you can prevent a preterm birth, even by a few weeks. So in summary, these initiatives were selected primarily under the rubric of the triple aim: better health, better quality at a lower cost. A lot of the focus of this presentation was on the cost aspects. The report has more information on the quality and the better health. So I'm going to turn it back over to Steve, who's going to talk about Get Healthy California.
Okay, great. Thanks a lot, Brendan. I'm going to speed up so we can get to our discussants. But let me also just acknowledge that Tim Brown and Will Dow on our faculty here gave very important feedback early on in the draft of this work, and also it's been externally vetted by about 6 economists and other data analysts around the country as well that will be acknowledged in the report. I think are acknowledged in the report. So we've benefited from work done by Brookings and Commonwealth and some others also. And it's very interesting because some of these estimates we've come up here actually are very close to estimates that Brookings and others are coming up with for the nation as a whole, with a somewhat similar, not exactly, but a somewhat similar set of interventions as well. So in terms of triangulation, this is very much in the realm of what the world looks like and what might be feasible. So let me do this. I'm going to not go through this part just to say that the Get Healthy California initiatives line up very well with the work that we're doing here with the Berkeley Forum, and that we're actually able to put some cost estimates onto some of the interventions that Get Healthy California has recommended. And it's probably not by chance because we had an overlap of about 4 or 5 members of us who are both involved in the Berkeley Forum and we're on the governor's task force for Get Healthy California. But as a result, in terms of Brent's work and a lot of others on our staff, we're actually able to suggest some specific measures, additional measures and indicators by which the state of California, under the Get Healthy California umbrella, can actually monitor changes over time. And these are some examples here of some of these indicator developments in asterisks. transparent information on cost and quality. We can identify unit cost drivers. We can estimate the percent of people receiving care based on these global budgets and global payments that Brent and I have talked about, et cetera. So let me talk here about where we're headed with Form 2, where we're likely to be headed with Form 2 in terms of the ongoing implementation. First of all, a lot of work's already going on in the state by various other groups on some of these initiatives, and the Forum voice has been able to lend greater momentum to those efforts, as well as putting some flesh on the bones in terms of some of the data analytics we've been able to provide. But there's three things in particular we're going to be working on over the next 12 to 18 months. One is palliative care. Unlike the rest of the country, still harmed by the death panel talks, right, among other things over the last couple of years. In California, we can engage this issue. And the leaders in the state feel, and already are doing some things about this. So the Get Healthy California Task Force on Palliative Care that Mark Smith from California Healthcare Foundation is chairing will be issuing a report this month and another one next month on what the state might do around palliative care to better meet the preferences of people who have advanced serious illness, perhaps end of life, perhaps not always the case. And we've been asked, the Berkeley Forum and the leaders, to react to those recommendations. We may also be doing some modeling work of different benefit packages for palliative care and different payment models for palliative care. So that's one thing we're definitely going to be working on, trying to move the ball along. Second area we're going to be working on is all the work we've been doing on accountable care organizations in the United States. We have some national surveys out that can be made specific to California in this regard, and we're going to be feeding some of the lessons learned into the developments here in California. We have 40 ACOs here in California that are rolling out in various forms, and we need to learn quickly what's working and what's not working as we try to get more people into these integrated care system models. So we'll be working on that. And third, and probably equally in importance, is we're going to continue to monitor the cost and utilization trends that you've seen throughout the report. We have what we think is now a unique data set specific to California. So the Congressional Budget Office, Brookings, and Commonwealth will continue to be publishing national figures and data on the impact of healthcare reform. No one has California-specific data as the level or at a level of granularity that we now have. We have about 100 backup slides we're not going to show you that drill down market by market, county by county, breaking it out by payer, breaking it out by who's in the 553 group and the extent to which they stay in that group the following year as well. And so we're going to try to take advantage of that and feedback reports perhaps every 4, 5, 6 months as we track that. So basically, we're going to work with others in the state on all of this as well. You can see some of those other groups there. The Integrated Healthcare Association is doing some work on palliative care. We'll be working with the professional associations that are already doing a lot of work in this area. And then, of course, trying to capitalize on some of our own independent research also. So we're going to get to your questions in a minute, but I really want to start off with our discussants and thank Tony and Wade for being with us today, because they're going to be able to bring this down to the ground floor level, so to speak, in terms of what's happening in their systems and what they see. I'm going to give them a brief introduction. We'll just do it alphabetically. Tony Barrueta on my immediate right, your left here, is Senior Vice President for Government Relations at the Kaiser Foundation Health Plan and Kaiser Foundation Hospitals. He represents Kaiser in Washington and many levels of government, and also chairs their National Health Policy Committee. But before he joined Kaiser, he was in Washington, D.C., private law practice representing HMOs and pharmacy benefit management companies and trade associations before Congress. So he's got a wide and varied background. He's on a number of boards here in the Bay Area in terms of his public service. And his background, he's got a degree from Boston College, a law degree from University of Texas at Austin. And just to show he remains really dangerous, he's actually licensed to practice law in California. So I'm blowing his cover there. Wade Rose. Yeah.
But I don't.
But he
so
doesn't, unfortunately. Yeah. And we could keep it that way. I'm sure Kaiser Permanente might appreciate that too. So also delighted to have Wade Rose with us. And I thanked Wade earlier. He spoke to my class, I think about 3 weeks ago right here, and really got a lot of enthusiastic response from our students about some of the work he and his colleagues are doing at Dignity. He is also equivalent position to Tony, Vice President of External and Governmental Relations. Dignity is the largest hospital system and provider in California and all of the Western United States. Like Tony, Wade serves on a number of boards, San Francisco Chamber of Commerce, Silicon Valley Leadership Group, and so forth. And he also has a fascinating background. He served in the early administration of Governor Brown, Jerry Brown, and also Governor Duke Mejian a few years ago. And he also has experience in the UC system at both UC Irvine and then in the private sector at USC. So we're just going to start, maybe Tony, with your observations, and then move to Wade.
So thanks, Steve. It's always an honor to be associated with the work of the university and the School of Public Health and Kaiser Permanente. We always love to find ways to be involved with the school. So thank you for the opportunity to be involved here. And as a Berkeleyan, I'm very proud to be here as well. Being a community member involved with the university is also a great thing. I think that this report is actually going to be quite helpful in terms of focusing policymakers' attention on what's really important. The slide that Steve showed at the beginning that showed the amount of coverage, the amount of payment that happens through more integrated approaches and global payment approaches versus the number of people who are insured that way is telling. It hadn't really occurred to me until it was outlined that way. And so when we're trying to promote policies that will encourage more global payment, that's something that's actually very important. I think it would be a fair point to make in looking at the presentation, given the people who are involved in the development of the presentation, that the target outcomes could be accused of being somewhat modest, given the criticality of the cost problems that we have in the healthcare system. And I can tell you that as a member of the healthcare industrial complex, there's pretty much nobody inside the healthcare industrial complex who doesn't have every day on their mind the fact that affordability and cost is an absolute critical problem that has to be addressed. We cannot simply continue to experience the cost increases that we've been having, and so it's a critical agenda for everybody who works inside healthcare systems. Everybody's aware that it's a problem. The real challenge is, how do you get off of the treadmill that we're on as a nation, really, in terms of a healthcare system, and onto something that is more sustainable over time. And all systems are going to be focused on this acutely over the next couple of years, because with the Affordable Care Act in particular, the Affordable Care Act makes this even more critical. We're taking much more of total healthcare payments, and it's being owned or subsidized by the government, and frankly, it's bankrupting the federal government and the state governments. And so there's going to be policy pressure on this. Healthcare organizations know this pressure is coming, and they're working very hard now to figure out how to address these problems. Looking at, for the group that met, the conversations were very good. One of the reasons that I think it landed where it landed appropriately in terms of the notion of global payment, in terms of bringing things away from utilization-based and unit-based payment and move it into a global payment system, is because the group couldn't talk about the other more direct approaches you might take to something like this. There's broad acknowledgement that, in fact, I brought my recent Time magazine. If you haven't read this article, I recommend all of you read it, because it's really, it tells the truth about a big part of the healthcare system. That's a big problem. But this group, because of it was the CEOs of the various organizations who supply one another, serve one another, and compete with one another, they can't sit down and talk about this stuff directly. What you can do is make this stuff less relevant by putting payment into a place where it's paid on a global basis, and you can't finesse it. You can't simply raise the prices or jack up the utilization and maintain your economics. You actually have to live within a budget. At Kaiser, we've always had to do that. Not to say that we're at all immune from many of the larger pressures of the healthcare economy. We are, you know, the majority of our costs are paying salaries to people, and we buy, you know, $4 or $5 billion in drugs a year, and there's all kinds of stuff that we have to deal with. But once the incentive is about how to solve to the target, you can start making a difference here. And I think that's what's really important. I mean, I'm really hopeful, Steve, that, you know, we can do a lot better than the percentages that we're talking about once we get on this path, and you can start changing the economics pretty aggressively. So even with the relatively modest targets that are set, I think what's important is the directional correctness of everybody in the industry understanding we need to move in that direction with, I think, an implicit understanding we need to get farther along that path if we're really going to solve the problems that we have. So I think, you know, I think it was a great effort. I think it's a continuing important effort. I think continuing to feed the data into the policy debate is critical, even if the purpose of this forum isn't to have everybody in the industry agree on exactly every policy outcome or policy approach to things. But I think it's a highly constructive contribution, not just to the debate here in California, where at 15 or 16%, we're still 3 points below the GDP percentage of the spending of percentage of GDP that's experienced in the country as a whole. I mean, we're kind of ahead of the game in California. What we need to do in California is figure it out so we can lead the rest of the country out of the problem that exists. So I think it's a great work, and I'm glad that it's continuing on, and you're going to keep supplying the information for the effort.
Great. Thank you, Tony. And just as we transition to Wade, two things that Tony said just to underscore in a different way. What's really important about this report, as much as the data and the findings, is who's saying it. You know, as Tony said, it's not us, the university. We helped, we provided the analytics, but this is their report. This is the leaders saying, let's go to global budgets. Forget about, we realize we have to transition, et cetera. Not everybody's prepared to take risk. You know, Kaiser can, maybe Dignity can in some respects, and so on. So there's going to be this incremental, you know, semi-capitation, bundled payment, you know, but they're basically saying, hey, we got to move faster than that, right? So it's who's saying this is important. And the second point, just to underline, is the fact that these estimates, and I know the policy and data wonks in the audience, I personally think, and a lot of others I've talked, they're actually conservative. Yeah. And we're not double counting. Brent didn't have a chance to go into it, but some of those interventions, you know, compiled together, are you double counting? To the extent we could, we're not. We're parceling out. There's limits to the extent you can do that. So I would just make that point as well. But Wade.
Thank you, Steve. Can you hear me?
I can hear you.
Tony and I go way back. We worked a lot together during the Obama, the passage of the ACA, and kind of illustrative of talking about the need to change healthcare. Dignity Health, we have about 41 hospitals, majority here in California, from San Diego to Redding and Sacramento to San Luis Obispo and LA, and pretty much covering the state. And what we are is and how we characterize ourselves during the debates in Congress is that Dignity Health is a reason there should be healthcare reform. And the reason for that is that we reflect how the majority of care is provided both in California and in the country, which is the fee-for-service system, which is the essentially community hospitals dealing with independent, small to medium-sized and solo practices of physicians, and all of the confusion that comes out of that. And the fact, from the perspective of the 21st century, is that the fee-for-service system pretty much reflects a middle 20th century, late 19th century organizational model and how to provide care, which was predicated on the science of the time. So it's a very antiquated and ultimately inefficient system, which carries a tremendous amount of financial burden with it today, and we need to let it go. And we need to move in to a 21st century model that is predicated on team care, on systems, on clinical coordination, and much more sophisticated organizational approach than is happening now. And Dignity Health, as I said, is an example of why we needed reform. And it still is an example of why we need reform, because we are in the midst of moving from a fee-for-service model into an integrated model, much like Kaiser already has. And that comes under this rubric of clinical integration and coordination. Now, part of the reason why that's necessary, especially from a clinical perspective, and Tony's touched on it a bit, is the biggest cost driver in healthcare outside of salaries, which run upwards of 60% of all our costs, is technology. And technology, according to OMB, is the major cost driver and primary motivator in healthcare inflation outside of demographics. And the irony about technology is, and its relationship to healthcare inflation, is that Berkeley contributes to it in a big way. UCLA does, Stanford does, all the medical schools do, because they are funded through an extraordinarily successful federal policy, which is called the National Institute of Health. That was created in the early 50s because after the war it became fairly apparent that if we put some money into biomedical research, great things would happen. So they did. Congress created the NIH, I think, in '52. The discussion started in '48. And as a result, we have this massive list of new discoveries in diagnostics and treatments, which is culminating in genetic medicine. But the problem is each new discovery represents a new opportunity to spend money. And the ethical and political structure in the U.S. prevents us from denying the application of a new therapy or a new diagnostic when somebody is pretty sick. Because who's going to say no to your mother getting the best care that you can imagine? Because there's a question about efficacy. It's a huge deal. It's an ironic deal, but it indicates the need for more sophisticated approaches to the judgment about the efficacy of care, which again got us into the issue of the death panels by Palin, bringing that up. But it's really a question of being able to make a rigorous, clinically sound scientific evaluation about whether a particular diagnostic or a particular intervention is worth it or not, especially at the end of life when a huge amount of care decisions are taking place. So this requires a much more sophisticated approach to the delivery of care, and that's central to the ACA and where we need to go. So what we're trying to do as both a state and a nation is literally take the single largest economic undertaking of the country, which is true also for California and is also true for the Bay Area by far. I mean, the healthcare accounts for approximately 18% of GDP. The next highest percentage of GDP is manufacturing at 8%. You could arguably say the business of America is healthcare. So we need to take this huge thing, which is growing like Topsy, and turn it into a more sophisticated, contemporarily understood and managed activity so that we can make sure it remains accessible to all people who need care, which would be you and me at some point in our lives. So this is a huge undertaking, and the best way to understand the ACA is that we have been given permission to modernize. It's going to take a long time to get there. Tony and I deal with an incredible implementation list of regulations and laws in order to implement the ACA, and then how to monitor it to make sure it works and that unintended consequences don't emerge, which is already happening, I assure you. But it is the right thing to do. It's the soundest thing to do, and activities as we engaged here and supported at UC Berkeley is part of the dialogue, which is, from our perspective, going to help us understand where it is we need to go.
Thank you, Wade, very much. Let's open it up. We have at least 15 minutes or so, and you've heard us talk enough, so your questions, observations, statements. And we've got microphones here, so raise your hand, and we'll get you a microphone. And if you want to just say your name quickly or affiliation, that would be terrific.
Anyone down here? Can I ask a question?
Oh, okay. I thought you were going to ask a question.
You can.
Charlene Harrington. I'd like to ask, for Dignity, does this mean that you're going to move into an HMO model, create your own HMO for the organization and move it in that direction?
In that direction. We have 4 already. They're regionally based. And we are looking at how we can scale them up. Now, it's quite difficult. In healthcare companies like ours, at Kaiser, we are cultures of behavior. And it's very, there's a saying in business, culture trumps strategy every day. So to change from our historical perspective into a more integrated, system-oriented and recognized perspective is going to be hard, but yes, we are moving in that direction.
My name is Peter Sherris. I'm a retired Kaiser physician, actually. I'm very interested as to how you're going to change the culture, especially of your providers,
Right.
who are used to doing stuff to people and ordering tests, and that's how they get paid. To essentially, I guess what you're saying is salaried model?
Yep. Yes.
How are you going to do
You know, it hates us to, I hate to say this, but this is the model right here, and you participate in it. There's no substitute in our estimation of a membership model where people become members of a service delivery system. And that, by necessity, incorporates physicians as a part of the delivery system. And that, by necessity, means the docs should be on salary in order to get them out of that context of basically being small business people. And it gets them also out of the context of having to manage the business, which I can assure you is, as you know, is just awful. It's an awful undertaking, very frustrating now. So yes, the employment model is the direction we're going. Now, is that going to happen overnight? No. But as you know, most of the kids, most of the people graduating from medical school and going into practice want a 9-to-5 job, want to focus on the delivery of care, not the business of care, and prefer the employment model. But it's going to take time. The big thing about this change is time.
They may need 8 to 6 jobs while we're implementing affordable care.
A little bit of efficiency someplace, right?
Just a lot of stuff that's happening.
I know.
Robin Flagg, I'm a PhD student here. Just given the answer to the last question and given the presentation, I'm wondering what's been done in terms of trying to engage physicians, the California Medical Association and others, and actually the community at large in terms of patient-centered care and health. I mean, what seemed to be missing from this discussion was the community-based organizations and other non-provider HMO groups, and I'm wondering if there's any movement towards including them.
Well, there were some providers, in the conversation. I think the hospital providers were pretty prominent, and having Bob Margolis in the conversation, where he's more of the integrated, IPA sort of model of physicians. But you're right, Robin. It's very difficult once you try to go beyond the cadre of physicians who have already bought into the notion of that you need integration. To go outside of this. I think what's important is to build infrastructure so that physicians, you have to remember there's 17,000 physicians coming out of medical school in the United States every year. And what we need to do is build infrastructure for new physicians to move into. And eventually the existing culture will age out as long as there is something there for people to be able to adopt early on. And frankly, it needs to be bigger than Kaiser Permanente. There need to be other options that are, similar models. And I think we think it's great that other organizations see the need to move in this direction. You know, the cultures don't have to be identical. They should, you know, every organization should have its own unique culture. But the basic notion of it should be available to more physicians that they can practice medicine and not have to worry about the business side of it. You know, you're talking about the technology, Wade, and you know, one of the roles that I had before I was in my current job, I was doing the policy work for our pharmacy program and working with the medical groups around choices and managing the formulary and decisions about technologies. And what's amazing about that is when you free physicians from having to worry about how much they can make based on what are they going to dispense or what are they going to prescribe or what implant are they going to, you know, use for somebody's knee, they really can look at exactly the things that you want them to look at and make decisions about exactly what you want them to make decisions about. You know, and it's not, you know, it doesn't swing from, oh, we need to do whatever's going to make the most money to whatever's going to cost the least. Mm-hmm. They really do come and look at it from what is the right thing for the patient. So it's about insulating physicians who are, you know, one of my colleagues, Sharon Levine at Kaiser, you know, she makes the point that, you know, this is the most expensive piece of medical technology in the world when it's held by a physician, because they're the ones who do the orders, and it's, you know, and it's about you want physicians to be making those orders about what's clinically appropriate and what do they think is really the best thing for the patient, and not worry about, you know, there's a 30% markup on this thing instead of a 10% markup on that thing. And I think we can move in that direction if we do the types of things that organizations like Dignity are trying to create an infrastructure for people who are outside of the Kaiser system.
Michael Stacy, I'm a physician and MPH student here. So it sounds, I mean, the bulk of these savings really come from global, or the bulk of the improvements to save money would come from these global payments. Sounds like what you're saying is to get there, it's incremental, building the infrastructure, maybe working on building global payments. I don't know for specific to, I'm interested in what that process is. And then the number for 2022, is that assuming full global payments across California, or what level of implementation does that number assume that is going to be achieved in 10 years?
What percentage of increase, Steve, was that?
Yeah, today it's at about 25%. In 2022, the goal was to have it be 70%. Right.
And your point, Michael, is one of the way to think about this is coevolution, if you will. Coevolution of the payment change, but you also need the capabilities of the system to respond to these new payment incentives. And we're not there yet. You know, Dignity's in the process, but there are others further behind than Dignity is, right? Kaiser's out there as a prime example and has been for decades. So it's kind of like, how do you manage the pace of change at the individual level, group level, organizational level, California-wide? Because there's going to be some losers in this that think they can take on the risk and will fail. We had that about 10 or 12 years ago. But hopefully we're developing more of the capabilities. And as Wade and Tony have said, we now have the ACE in effect, something to point to and give us the opportunity to do this. And we have people changing to these new payment models, including now in our state, public declaration, global budgets. Let's move it, you know, Brent has said. And so we think this is feasible. It's not going to be easy. It'll revolve at different, you know, stages up and down the state. But it also sends a signal then to the foundations in the state, to others of where help may be needed and where innovation may need to be encouraged along a little bit.
So there's a roadmap for change, which is the Affordable Care Act. And it's clinically pretty sound. But what it represents is a huge source of disruption in the American healthcare system. But what that means is there's going to be a huge amount of innovation in order to respond to that. And the innovation will cause a disruption. And as a result of that, there will be a tremendous amount of experimentation and failure as ideas are tested. And that's been anticipated in the ACA. So that's It's actually what we are engaged now is in the front end of the disruption. And it's going to be confusing. It's not going to be linear. It's going to be scattered. There'll be lots of failures and lots of successes as we hone down toward being comfortable with the new system of care. But we pretty much know what that new system of care is, which is essentially better management of what we do.
Yeah, there's probably one other thing that needs to happen, and almost perfectly matching our incredible overinvestment by world standards in healthcare services and everything that goes on there. We have a really woeful underinvestment in social services by world standards, and so in some respects, when Brent was talking about the fact that 10% of what really can drive things is drive health in general is healthcare interventions. Really 40% is around behaviors, activity, issues like this. That's why walking is on this list. And I think, frankly, it can have a much bigger impact than what's there. But to make that happen in the communities where it really needs to happen, there's a lot of true social work that needs to go on that isn't just social workers signing people up for Medi-Cal. Right. It's actually helping people figure out how to live their lives in a way that's healthier and creates less need for and gets in front of the healthcare system. One thing that I would worry about is if suddenly the existing healthcare system adopted all of those services and made them healthcare services, because then you're doing it on economics that are at a multiple of what it would be if they're social services. So that's something I think people need to keep an eye on, because there is a very acute need for investment in community services of that nature and figuring out business models. Yeah. And some people are figuring out business models on how to do that stuff. And I think that's going to be a place to watch, because it's about getting in front of the healthcare system.
Some people are beginning to talk not just about accountable care organizations, but about community care organizations. Yeah. And the UK actually does this much, much better than we do, if you look there. And so that's an example, looking to other countries, what we might be able to do here. But a lot of other questions are popping up.
My name is Jing Li. I'm also a PhD student here at Berkeley's School of Public Health. I'm actually also very interested in sort of the specific predictions about the cost savings that's going to be generated through shifting from fee-for-service to global budget. So in the presentation, we know that it's a challenge to sort of predict accurately how physicians and providers are going to respond to this shift, to this sort of change in payment. So I was just wondering, for the purpose of the prediction of the cost savings, are there specific assumptions that we make in order to do the predictions, or what are the essential pieces that are underlying this prediction?
Right, so I'll let Brent go into that in detail, but the short answer is yes, we used a lot of existing studies, and it gives me a chance to say by next Friday, we will have the appendices in detail posted. And that's going to go into all of the assumptions we made, the data sources, and so forth. We'll really address your question in detail, but Brent, you may want to just hit the highlights.
Yeah, he summarized it well, that we used existing evidence where it was available. In this case, there was existing evidence of what the savings Blue Shield generated in Sacramento, what Blue Cross Blue Shield of Massachusetts generated. These were published, peer-reviewed, and then the Medicare Physician Demonstration Project. So all these, in this case, the evidence is fairly strong.
And the behavioral translation of that is fewer patients being readmitted to the hospital, fewer patients being admitted to the hospital to begin with that don't need to be there, fewer emergency department visits, reduce the number of office visits. You know, if you've got a budget, you can be creative and innovative. You know, why do we have so many office visits, right? We have these at-home technologies and so forth, right? Better clinical management of care on a day-to-day basis. Those are the behavioral changes that we're beginning to notice to some extent around the country that will result in these lower costs.
Is this on? All right, good. My ears are a little clogged, sorry. So I used to be a doctoral student here at Berkeley, and I want to go back to the comment about the community level interventions. So I've done a little bit of work with community health centers. And so when I'm thinking about my healthcare home of the future, am I thinking something on the scale of a house or something on the scale of a massive high-rise with 600 units in it, according to the optimal models that you guys are talking about?
It's a good question.
A house. Yeah.
We're doing the high rise. No, I mean, I think it's a really good question, and in fact, I think the community health centers have an important role in this too, because they already can show the way that they've integrated healthcare services with the other services that are available, particularly to populations who need things, particularly socioeconomically disadvantaged. One of the interesting things is, in some respects, there needs to be social support for everybody else. And the social support for the people who are disadvantaged needs to be upgraded to include things other than the kinds of things that they're getting now. And so I know at Kaiser, we are deeply engaged in the local community efforts that are going on in terms of healthcare, and particularly trying to help them figure out, and we learn at least as much from them as they learn from us, how to modernize and provide effectively what needs to be provided. I mean, there's so many things that have, when you look at what the communities look like, can people even leave their house at night to walk someplace? I mean, those are the things that have a critical impact on, fear that parents have about their children has driven, other types of behaviors that reduce activity. And then I'm not even getting into the food side of things, despite that. So there's a ton of stuff that can be done on that side, that needs to be done on that side in parallel to making the healthcare system more responsive to people's needs. And I think the fact that, finding a model for practitioners to move where they can live good lives and provide the service that they got into it for, that they want to provide, and at the same time meet people's needs, that is just as necessary. So I like the way that the Forum Report lines these various things up, because it creates focus for very different things that need to happen at the same time.
Well, the things you're talking about are almost sounding pretty public healthy. So would you be willing to endorse the concept of medicine as a subset of public health?
Absolutely.
I don't know if I'm authorized to do that.
Yeah.
I can.
I don't even know what I'm signing up for if I said that.
We're actually the only school of public health in the country that has a medical school within the School of Public Health. It's a joint medical program, so we've did it for 35 years.
Well, it's partially this. When we were in the midst of the ACA debate, we're working on why has this taken so long to get as close as we were getting. Eventually got there, and what it came down to is there's a archetype psychology associated with in people's head with healthcare, and that's basically it's a 19th century model of care. It's the single doc with a leather bag, right? It's Marcus Willoughby was the latest manifestation of that. It's almost like dream analysis. You have to you have to ask yourself to understand this metaphor, what's in the bag? You have to open up the bag. And if you open up the bag with that metaphor, you find in it a stethoscope and something to hit your knee on to check your reflexes, but not much more, except the physician's ability to relate to you, which was incredibly important. Today, one person couldn't hold that bag. There is so much in it. It is just absolutely mind-boggling. So the metaphor today should be a team. It should be a group of people who have the expertise in coordinated jobs that can bring the totality of our skills to bear on you. And if you don't have that in your mind with your healthcare provider, then you're probably not getting the best care you can get. So you want to switch this image from an individual to a team. And that gets you into questions of scale, which you're bringing up. And you want a team that's not so big you lose track of it, right? Then you become alienated within that framework. But you want to be able to encompass the relationship in your head. So that argues in our estimation for a house and a community clinic. Now, you can't have that everywhere, and you have to scale up at some point for efficiencies. depending upon the level of care you're getting. But you want to have access to a community clinic that's yours, and you're a member of it. It's not just something you enter by happenstance. You actually have an integrated relationship with it, much like the European systems are built. And that's where you'll get better care.
I'm very conscious of the time, but we have time for maybe one or two final questions, if there are any.
I wasn't going to make a comment. I was going to make a comment. I was going to say, rather than thinking of an individual, you should be thinking of a family. So it's a team working with families.
Yeah.
Yeah, right. Yeah, Michael, last question. I see hand raised there. Okay, you get a twofer.
This is also a little bit more of a follow-up comment to the public health issue. I actually work in a local health department, and I think strengthening those linkages between the healthcare system and not only the state health department, but where in California particularly, where we have these county health departments that work in all of the individual counties, it becomes a little bit more complicated, but that's often really where the boots are on the ground that get that work done that you're talking about, getting, taking care of food deserts, safe, building safe routes, trying to work with city planners to build safe neighborhoods, and they're very, and us at the local level, we're very aware of the communities that we serve. So building those linkages would be good for you, good for us, and what we lack are the resources,
right?
At the local health department level. So that those linkages would actually really help for some of these preventive cost savings.
Yeah, I have to tell you that at least, and I think it's true in a lot of organizations, but at Kaiser, we've really the senior leadership and I think across the organization have landed on this concept of total health, which is that you have to focus on more than the medical care that you're delivering. And when you look at total health, you are talking about these other things. And we completely believe that we need to find better ways to integrate into the things that are going on in the community to participate in that. It has to be open, it shouldn't be exclusive type stuff. And in order to do it efficiently, oddly, you have to do it broadly. Which is the truth of public health, right? So I think we're going to see a lot more of that in the coming years, and I think we're going to be doing that. I think other large healthcare organizations are realizing the same things and are going to be doing the same thing. So I actually think I'm very optimistic that we're going to be moving much more in that direction.
So we're really pleased we had the opportunity to share this with you, and please join me in thanking Tony and Wade and Brent and everyone.
Thank you.
Thank you.